All right, let's go ahead and get started. Good morning, everybody. I'll get through these quick intro things, then I'm going to turn over to Gayle and Ken for today's presentation. So I'm Will Schmeckley, Project Coordinator at the Nebraska Medical Association. Welcome to our third of 4 trainings in this current series on treating patients with buprenorphine. Again, this slide just says everyone involved in this project. We have no financial relationships to disclose. Funding statement, again, we're grant funded through the State Opioid Response Grant from SAMHSA. Those grant funds come to Nebraska DHHS and are passed down to us. So we thank our partners at DHHS for helping us make these trainings possible. Usual thing with the CME certificate. Later this morning, I will get an email out to everyone with that link to the quick evaluation survey. Once you do that survey, you'll get your certificate. And I think at this point, we all know what Project ECHO is. For those of you who are new, we may have a few new people today. ECHO stands for Extension for Community Health Outcomes. And these are ongoing trainings and consultations on treating patients with substance use disorders and pain. Sort of a hub and spoke model. We've got an excellent team of experts on our hub team who are able to consult on these trainings or outside these trainings if needed. And like I said, these are ongoing trainings. So our current series is, we've got one more after this, and then we'll pause in September, and we'll be back in October and November with a new set of 4 trainings. So I'll have some more information about that probably in the next time. And then I'm going to let our ECHO team introduce themselves. Let's see, Janet, would you like to start first?
Yeah, I'm Janet Bernard. I'm a retired family physician in North Platte and treated opiate addiction with Suboxone and related medications since 2008.
Great. Todd, how about you?
Good morning, Todd Stull. I'm a psychiatrist that's worked a lot in addiction.
Thanks. Ed?
Yeah, Nathan Ed Kaiser, nurse practitioner in Omaha, Nebraska. Work with Ideal Option, which we do substance use disorder, but been treating patients with substance use disorder for about the last 5 years. So yeah, excited to be a part of this team.
Thanks. John?
Hi, I'm John Massey. I'm a interventional pain physician here in a number of communities, and I do a lot of work with patients with both chronic pain and substance use disorder.
Great. I don't see Stephanie on, so Gayle and Ken, I'll turn it over to you two and let you take it away for us.
All right. I'm Gayle Keller. I'm a family and psychiatric nurse practitioner in Falls City, Nebraska, and I also treat patients with substance use disorder.
Hey, my name is Ken Zoucha. I'm a pediatrician and addiction medicine physician, and have primarily an adolescent and young adult population, as well as pregnant women, and been treating adolescents with substance use disorders now for 13, 14 years, I guess. So thank you for allowing me to be part of the ECHO today. I really appreciate it. So Gayle, do you want me to share screen?
Sure, that'd be great.
Okay, I can definitely do that. So let me get going here. All right, I'm hoping you guys can see the screen. Does it look okay? All right. So Gayle, do you want to go ahead and start?
Yeah, that'd be great. Today, our discussion is just success to treatment and using all providers, including physicians, physician assistants, and nurse practitioners who are wanting to implement medication for opioid use disorder. The reason why we want MAT implemented in our state is that MAT saves lives. Opioids are one of the top causes of death in this country, even despite all the work that has been done in the last 5 to 10 years. And unfortunately, the reality is, despite reduction in opioid prescribing, this alone has not led to reduction in drug mortality. We also need to keep in mind the true impact of the opioid crisis, which reaches beyond the number of Americans who die from drug overdose. It includes the unprecedented number of children entering foster care due to the parental substance abuse and record increases in both number of babies born with neonatal abstinence syndrome and the loss of productivity in the U.S. workforce. Improving the access to medication-assisted treatments can have profound impact on individuals with opioid use disorder, their families, and the health of our nation. Today, I'm going to talk about low barrier treatment, connection to care and community, culture and harm reduction, and utilizing all providers. NPs and PAs, I feel, are ideally positioned to assist in combating a major portion of the opioid epidemic. These providers have met ongoing needs for expansion of primary care services and have displayed proficiency in the role.
I'm really, again, grateful for the opportunity to be here today, and wanted to, my part's just a very small part of today. Gayle's really the one who has the experience and the ability to talk about how APPs or advanced practice providers can be part of the solution. There'll never be enough addiction medicine physicians. There'll never be enough psychiatrists. Our primary care physicians and providers, physicians, assistants, and nurse practitioners have to be on the front line of this if we're going to make a dent in reducing the number of folks that are struggling with substance use disorders, as well as decreasing the number of deaths. And so I wanted to go through a couple of things about how the country moved into having our physician assistants and nurse practitioners be able to provide care. We got into like the 2014, 2015 range and realized that we were really struggling getting physicians to apply for the waiver. And I'm going to talk about that in a little bit. But as a result of that, there's been several acts kind of in the history of how we brought nurse practitioners and physicians assistants into the realm of this work in a multidisciplinary and really team approach that has to happen to treat patients with substance use disorders. So the first thing was the TREAT Act, and it stood for the Temporary Reciprocity to Ensure Access to Treatment Act. And so it was a part of a larger bill that allowed nurse practitioners and physicians assistants to practice. You can see that practice under the supervision of a licensed doc or physician who had an active waiver to provide opioid medications for opioid use disorder, and allowed the nurse practitioners and physicians assistants with 24 hours of training in collaboration with a physician, and it was an advocacy to start kind of changing and bringing more providers into the realm of being able to prescribe these life-saving medications. And then in 2016 was the Comprehensive Addiction Recovery Act, and it was a provision of a bigger thing called CAPTA, which was the Child Abuse Prevention Treatment Act. And it was really, a lot of that was focused on increasing our care and improving our care for infants born to mothers who have substance use disorders, who are on medications for substance use disorders, and to really accelerate that. And there were some kind of rules in there. The states had to develop strategies to help infants and families so that we can improve care and provide the most and best evidence-based treatment to our families so that they could stay together and find recovery and all grow in a healthy way. But in there, there's a little bit of a change that said supervision if required by state law. And at that time, Nebraska had allowed nurse practitioners to practice independently. And so it allowed our nurse practitioners to be able to do that. But the waiver, again, required 24 hours of training. And in 2021, there was a reevaluation of that law. I wanted to throw this map up. This is from 2018, and it's the white areas are counties where there are no providers that were able to prescribe buprenorphine or had the waiver. And, you know, everybody knows now that after December of 2022, we don't need that waiver any longer to be able to prescribe medications to treat opioid use disorder. But what this showed was at that time in Nebraska, that we had 3 counties that had a physician and an APP that were able to provide medications for opioid use disorder, who had gotten the waiver and were willing to do that. And you can see that it's the Omaha area, Lincoln, and then our good friends in North Platte with Dr. Janet and the ability to be able to provide that service. And you know, Dr. Janet was that kind of warrior out there that was started doing this, you know, way before anybody else did in that part of our state. We've had some folks in the Omaha, Lincoln area that have been doing it for a long time, Dr. Stahl being one of those. But, you know, I think that this really shows that most of our areas in Nebraska did not have providers who were able to prescribe buprenorphine to treat opioid use disorders. And I think it's a stark kind of a map too, because it just shows that our coasts where the opioid, arguably the opioid burden was much higher, had more prescribers in those areas. But in our Midwest area, we still have that burden, you know, although we only had, you know, 150 or 200 deaths per year from substance use disorder or overdoses. And there were states that had that per month. We were still having citizens in our state dying from overdoses. And so it was a call to action at that time. I wanted to talk about some barriers. And so there's been several articles kind of looking at why physicians don't prescribe buprenorphine and why they either didn't obtain the waiver, or if they did, they didn't use the waiver. And just to show you, in 2019, only 7% of U.S. physicians had the waiver. And right now, you know, we don't need the waiver any longer to be able to prescribe buprenorphine, but I equate that to physicians who are willing to treat anybody who has a substance use disorders. And so if you're willing to get the waiver to prescribe and are doing that, then you're also willing to have patients and do the assessment and management of patients who have substance use disorders in your practice. In 2017, 45% of the waivered physicians were prescribing, and the numbers went down, even though there was a slight increase in the number of physicians who had gotten the waiver in that 4 years. There were less of them who, percentage-wise, who were continuing to prescribe buprenorphine at that point. So, you know, that's a pretty kind of, I think, telling tale about just how few physicians were doing this work. And there's a lot of reasons that the physicians and offices gave for why they weren't doing that. That involve things like insufficient nursing support, payment issues, lack of knowledge surrounding how to assess and treat substance use disorders, low demand, insufficient physician knowledge that I think is probably a little bit higher than what it talks about here. When I was in medical school, you know, we got a 1-hour thing on substance use disorders in the 4 years that I was there. And in my residency, there was no training surrounding substance use disorders. And so we're really working hard to improve what we're doing for training for our physicians coming out into our state and beyond, to be able to have more comfort being able to prescribe medications, as well as just to screen, assess, and either treat or refer patients with substance use disorders. There's a large percentage of patients who enter treatment who, when asked, will say that their own primary care physician never asked them about their substance use disorders or asked any questions surrounding that. And so we just have to get better at just training our folks, including our APPs, you know, physician assistants and nurse practitioners, how to do that. So if the barriers were improved or removed, here's what it looks like. We've got a big number that would consider that if there was help out there, if there was more knowledge, if there was mentoring, if there was improvement in payment, and also just kind of working on that stigma piece of it as well. And we have physician assistants in our office at Nebraska Medicine. We have an addiction treatment clinic. When I think about that, I've had a friendship with Gayle now for a long time. Just kind of thinking about like how that works. And here's the things that are possible if an APP is involved in this care. Is it basically you just see more patients are being seen. I think arguably APPs are better at like the education surrounding everything basically, but also for substance use disorders, and there's coordination of care, and there's assistance with the pharmacies and with the authorizations, the social part of this, and just greater number of patients are seen, and allows for patients to get care within their community. The other part of this is the stigma piece, and I know stigma has been touched on and talked about a lot, but just bringing that into our medical offices and bringing it to our medical care is part of removing that stigma. We have to be the models for that, and allows physicians who have more extensive training to evaluate and manage those more complex patients, because our partners, our physicians assistants and nurse practitioners, our partners in care, are able to help see more patients. So I'm going to pass off to Gayle now. So thanks for giving me a couple of minutes.
Thank you, Ken. So I'm going to kind of talk about low barrier treatment. And the thing with opioid addiction is that we really need to have it readily available and accessible to those who need it. Addiction can alter one's brain chemistry, which can affect motivation, inhibition, and stress tolerance. And when patients are motivated and ready to engage in treatment for their substance use disorder, it is important that we can seize the moment and connect them to the appropriate treatment as soon as possible. It seems as if starting patients on medications on the same day they are first seen by a provider improves retention in treatment. Originally, clinical recommendations for the use of buprenorphine to treat opioid use disorder were heavily influenced by strict methadone regulations, but these practices have been lifted. And so it has made it a lot easier for us to participate in this care. One thing that I think about with my opioid use disorder initiation with buprenorphine is that a lot of times when I started doing this, it was during COVID. And so we really didn't have the opportunity to perform inductions in medical settings. So home inductions were done, and that was successful with just education, a little bit of support and follow-up calls and communication. And it was safe and it was effective. Other things that I think about with MAT is that traditionally with buprenorphine, if a patient was taking a benzodiazepine or other substances, we withheld care. And that has been shown to be potentially harmful for an untreated person to have opioid use disorder. The risk versus the benefits, the treatment outweighs the risk for using both medicines. The other thing is with low barrier treatment is that it seems like there's a lot of people getting creative of how they initiate care. In California, there's an ER physician who talks about how she implements care in the ER, and she's even started people on Suboxone as they are waiting in the waiting room to be seen. Family practice, typically we have scheduled appointments, but sometimes it's important to have walk-in clinics to help with initiation and follow-ups, and also just to kind of help with those people that have jobs. I know Ken and I, when we were talking about this, Ken had discussed it that in Utah, they were using group appointments for stable patients. And I don't know if you want to kind of talk a little bit about that, Ken.
Sure. This is a strategy that I think just the folks in Utah, but across the country are using, where stable patients can come in for group appointments. And it's one of the things that we are going to be starting in our clinic because we have so many patients that we just can't see them all. And it just, we're having to extend our office, just all the things that go into that. So just the group appointments allowed folks to come in and see their provider. And so in that setting, there was a physician and a nurse practitioner in that setting. So both of them were there. Both of them were sort of running a group. One of them was documenting while the group was happening. So the documentation was being done right there and then. And then once the group is over, then this 10 patients that came to this had their appointments done. They had some advantage. They had a pharmacy right there, so patients could just walk over and get their medicines right there on the same floor. If they needed more extensive care, they had another nurse practitioner who could take them into an office and go ahead and see them and kind of manage some more complex issues if they showed up. But it was an amazing strategy. So within an hour, 10 patients were seen, and they were able to bill a 99214 for those patients, and it was working for them. They were having no trouble getting payment for those encounters, and arguably, instead of using 2.5 hours to see 10 patients, they were able to see 10 patients in an hour. And so it was a pretty impressive way of managing that. And they were using sort of a walk-ins kind of strategy. So whoever kind of showed up were able to come and do that, and they had specific hours. So anyway, I just really feel like there's a place for that in busy practices to be able to see patients without overwhelming their staff, because there's a lot of folks out there that need this care. So thanks, Gayle.
Yeah, thank you. The next thing I'm going to talk about is connection to care and community. And really, there's no single treatment approach that is best for everyone. The treatment for substance use disorders should consider each patient's unique social, mental, and environmental needs and tailor the type and intensity of services offered to those patients. Treatment plans should be regularly assessed and modified to meet the patient's changing needs. For example, someone in like the early stages of treatment may want help meeting basic needs such as housing, food, energy assistance, and transportation before engaging in regular counseling appointments. Practice should consider how to incorporate patient-centered care principles as they design their service models and approach. Programs can also develop strategies to help identify patients who may be at risk for leaving treatment. And staff should work together to address patients' unique barriers to care and try to keep them engaged in the program. Patient needs and preferences should help inform on how to develop the systems and the workflows. For example, again, offering hours dedicated to walk-in clinics and during the evening and the weekends to accommodate patient schedules. Also, with this, it's important to build community partnerships. And over the years, I have worked with law enforcement, EMS, and we have a program called the Southeast Nebraska Community Action Program, where there's a gal down there named Sherry, and she is my rock star. I can send people down there and she will help them sign up for Medicaid. She will help them with SNAP. She will help them get transportation and food and housing. She's also really good about looking at, hey, we need to get your birth certificate, your social security card, and helps them find employment. So she is just, if I could replicate her, I would. She is just a great lady. I've also reached out to Region 5 Systems, the health department. And then I know Ken had previously talked about a program called Housing First, which was developed in Massachusetts. And I don't know if you want to kind of talk about that a little bit, Ken.
Well, it's based in our strategy of harm reduction, and really a lot of what Gayle's been talking about today. That is really the focus. Is going ahead and prescribing buprenorphine despite somebody being on a benzodiazepine, or possibly somebody who still using alcohol or other substances that we used to think that was just a no-no. But one of those strategies is a housing first strategy, and it used to be and still can be a lot of places where a person had to first be in recovery before they could apply or be considered appropriate for housing situations. And all the studies have shown that if we provide housing without that requirement, there's a large number of folks who get better and improve their substance use significantly just by having a safe place to live. It's Maslow's triangle, and being able to provide a warm place with some food and a place to sleep that's safe. And those two things are huge for so many patients. So that's just one of the strategies in this harm reduction approach that really works for folks with substance use disorders.
Yeah, and last night I was just kind of messing around, and I found in 2017 the Massachusetts Housing and Shelter Alliance published a report that an individual's annual cost before entering permanent housing was over $37,000. Once they were permanently housed, the annual cost was down to $25,000. And then prior to having housing, the estimated medical expense was around $30,000. And once they were housed, that number was reduced to around $10,000. So it can really make a big impact in your community, just with the financials as well.
Well, and there's also a large reduction in crime in the areas that provide housing first strategies, which is another, I think, thing that communities look at. And so I just think that's pretty amazing.
It is pretty awesome. The next thing I'm going to talk about is culture and harm reduction. And addiction is complex, yet a treatable disease that affects the brain. And we need to just recognize that reoccurrence is a common part of addiction. And I kind of think about, hey, if I saw a diabetic last month or 3 months ago and their hemoglobin A1C was 7%, and then in 3 months they come back and it's up to 10%, I don't turn them away. We, begin kind of talking about strategies, what has happened over the last 3 months, and try to see if we need to kind of shift or pivot our care a little bit to get them back on track again. And that's kind of the same way that I think about addiction. It doesn't necessarily mean that these patients are failing treatment, but rather they just require more support. I know with my practice too, I do use drug testing as more of a tool to indicate progress towards treatment goals, rather than a method of punishment or a reason to remove a patient from the buprenorphine treatment. The other thing is that I think it took me a while to kind of take into consideration is polysubstance use is very common among individuals with opioid use disorder. And different substances may require different treatment strategies or clinical approaches. Continued use of the other substances should not necessarily be viewed as an indicator that MAT is not successful, but rather the patient may need adjunctive services. Providers should consider taking harm reduction approaches related to the use of other substances and maintaining these patients in treatment. Sometimes too, I think what is important for me to remember that patients don't necessarily know or care about what I know, but they care about how I make them feel, because they already know stigma, shame, guilt, and judgment and suffering. And when they come in for an evaluation or follow-ups, they are showing up and they are looking for an opportunity to do better. And so I just think that it's important that we keep that in mind. And I don't have anything else beyond that, but I do have a couple of case studies if anybody wants to have any comments or anything right now. Otherwise, I can go ahead and do a case study.
That's an excellent presentation, you guys. Thank you very much. One of the things when we move into the case study, I think it's good to kind of talk over the echo process. We haven't done a lot of that so far, but typically when we do that, what we'll want to do is present the case and then allow folks to ask questions about that, and then come up, and then usually what we try to do is get the people on the call to come up with strategies and answers and or additional information needed to come up with that. So remind ourselves that we're trying to make this accessible to all.
Yeah.
Great presentation, you guys.
Okay, thank you. And like I said, I know when I used to come to the Project Echoes, I had brought some patient questions and concerns, and it was just so helpful to get everybody's opinion about how to go about treatment strategies. So I didn't know if anybody had anybody in mind or a patient that they wanted to discuss. All right, so I'll start. So with my first case study, I had a 34-year-old male present to the clinic for evaluation of his kratom use. And kratom is an unregulated herbal supplement that has been on the rise in the United States. It is considered a psychotropic tropical tree, and it's indigenous to Southeast Asia, Africa, and New Guinea. It is considered an opioid agonist with abuse potential, and its use is not federally regulated. And living in a small community, I wasn't necessarily completely aware or understood the herbal supplement. And so I did reach out to Ken regarding this patient. But a little bit of a backstory on him. He reported around the age of 16 that he was introduced to opioids. He had suffered 12 shoulder dislocations in about a 3-year span, and then he had surgery. And post-operatively, he was prescribed opioids for 4 months. And then he just kind of felt like, he couldn't get off of them. His parents had them available. His grandparents had them available. So he was always kind of dipping into their prescriptions. He also reported to me that, the opioids took care of everything for him, socially, emotionally, spiritually. And he did get into some health problems where his use escalated, where he did have an overdose. He did attend rehab on a couple occasions, and then he would kind of start sliding back into polysubstance abuse. He did have a good friend who suffered from opioid use disorder. And at that time, he was suffering from methamphetamine use disorder and opioids. But together they came together and they started working out and fishing and just spending time together. And they were able to cut back, and he was able to get off the methamphetamine. He noted weight gain, he was doing really well, but he just could not get off the Oxycontin. He said that, I would try to use just enough so I would avoid getting sick. So he read up on kratom, and he decided, hey, he'd give kratom a shot. And so he started using kratom, and he used it for about 12 to 18 months with an escalation in use. He couldn't cut back. He was having constipation and abdominal pain. He was initially taking it 3 to 5 times a day, and he began taking about 6 capsules. And by the time I saw him, he was up to 12 capsules with each dose. With his social history or family history, he reported a lot of trauma. His mom had methamphetamine use disorder and alcohol use disorder. He said at about 1 year of age, his mom had left the kids in the van to die, and his 3-year-old sister ended up getting out and found help. And he just felt as if he had a lot of heartbreak and void growing up. He now is currently married and was working full time, but he really wanted to be able to get off the kratom. And so I don't know if anybody has any thoughts about this, and then I'll kind of share what I ended up doing.
Hey, this is Amber. So I'm glad that you brought Kratom up because interestingly, just on Monday, I did an eval on one of my veterans, and I think I've actually had 2 veterans come through with Kratom abuse. And I don't know what it is. My veterans are educating me on what the hell it is. And so how to help them and how to treat them is, yeah, I definitely would like to know more.
From what I have seen is like what the effects of the kratom is dose dependent. I've had some patients that kind of tell me that, hey, it resembles an opioid to them. And then I've had some patients tell me that it kind of reminds them when they use methamphetamine. And so I think that's probably why it was so attractive to this patient. And I do have a couple of patients that dabble with the kratom, but that's been kind of my only experience with it. I don't know, Ken, I know that we've talked about it quite a bit, but if you had anything else to add.
Yeah, kratom's, it's so interesting because you can buy it at a gas station, and so low doses. So it comes from a plant in Asia, and the folks there actually chew the leaves from the bush to gain energy, to allow them to work in the fields for long hours. So at lower doses, it has a stimulatory effect by increasing noradrenaline as well as dopamine. And so as it increases those amine transmitters, there's an energy kind of a component to it. So that's how it's used in that part of the world. However, when ground up and put in capsules and then at higher doses, then it becomes a mu opioid receptor agonist, maybe partial agonist, and then allows for some of the same effects from just an opioid. And a lot of folks are using it because of actually just not being able to find any opioids, or just being fearful, or just wanting to get off. And so they've heard that they can use it for that. However, it's touted for like everything under the sun as a treatment for that. So what we've been doing, we have a lot of folks, we've been treating it like opioid use disorder. So we've been putting them on Suboxone, or if they don't want to be on that, working with them, getting through the withdrawal part for like 10, 12 days or so, and then putting them on naltrexone. It works really well for that. The Suboxone especially, I think, is a really good, buprenorphine is a really good medicine to treat folks that become dependent or develop a use disorder with that. And it's, the vast majority of the time, in fact, I don't have a situation where it wasn't somebody who had a substance use disorder before and then started using kratom. It's never like an initial thing for people to use. And the other thing I think is mainly because of it has that dual thing of the stimulant effect, as well as the tolerance is incredible. Just like Gayle said, they go from the folks can go from a few capsules a day to 20 capsules 6 times a day over a really short period of time. And the withdrawal is pretty nasty when people stop that. And so they have some pretty significant withdrawal symptoms. So it keeps them going. And then you can actually buy it in a powder too, and mix it into a tea. It totally unregulated. There was about a year and a half ago, there was a big salmonella outbreak from that, because salmonella had gotten into that kratom supply. And so, totally unregulated. So you have no idea how much kratom, the metragenin speciosa, the plant is in that, what they use for fillers, things like that. So basically, all the stuff pretty much says just treat it like an opioid use disorder, and as you would if somebody came in with a use disorder to oxycodone or fentanyl or another opioid. I hope that's helpful.
Yeah, thank you. Thanks, Ken. So after I talked to Ken, he recommended that we do try some Suboxone. And then I started to kind of run into some other problems where when I phoned the local pharmacy, They did not have Suboxone, and he already lived 30 minutes away from me. So I tried a second pharmacy, which would be like an hour drive for him. They had Suboxone, but they weren't willing to split the box. And so finally, I was able to reach out to a third pharmacy, which was over an hour away drive for this patient. And they agreed to split the box. And so he was able to begin Suboxone. We talked about the dosing, the Suboxone 8 milligrams. And I gave him like a SOUS score, which, you know, they kind of go through their symptoms. And we were shooting for a score greater than 17. So he would be in moderate withdrawal. And then he would take a half of the film and he would wait like 1 to 3 hours and see if his withdrawal symptoms would persist. And then he would take another film. And after he could continue to do that up to 12 milligrams. And then over a course of a few days, we ended up titrating him up to Suboxone 8 milligrams 3 times a day. So now it's been about a year since he has been receiving Suboxone. He's currently taking the 8 milligrams Suboxone, and he takes 1 to 2 a day. He's been gradually trying to wean and just see how he does. He's working full time. He's providing for his wife, and they do have a new baby. He's established a relationship with a sponsor, and he also during that time would take advantage of like food bank and food pantry opportunities. And so he's been doing really well.
Gayle, Ed Kaiser here. I just wanted to echo, thanks for bringing up Kratom. Like when I started in addiction 5 years ago, like I had no idea what Kratom was. And like the devastation that we see across the United States with opiates, like I wish Kratom was illegal because it's just really bad. But one of the things that a couple of my patients have told me is it does come in a liquid form as well. And so they've told me that the liquid feels even stronger than like the powder or the tablets. And so one thing I'll ask my patients when they're starting on Suboxone is like, how long does it take you to start feeling really bad or getting sick, to where you mentioned like starting them on the medication? And so sometimes that's helpful as like a target dose at times of like, if they get sick within like 5 or 6 hours, you know, sometimes they need a little bit higher dose or whatever. But yeah, there's a lot of people that switch to Kratom. And so thanks for bringing that up. I think if Kratom was not around, that would be a good thing. So I'm glad you're treating it.
Mm-hmm. I do have another patient that we can talk about if anybody else, nobody else has anything to talk about or wants to share. Okay, so the next fella that I have, he's a 62-year-old male with polysubstance use disorder. He began using drugs around the age of 14. He has been in and out of rehab at least 6 times. He has previously tried naltrexone, acamprosate, Suboxone. When he was tried Suboxone, he felt like he was on methamphetamine and dilaudid, and he was really scared that he was going to misuse the medication, and so he stopped it. He has been seeing a drug and alcohol counselor weekly since 2019, and he's been seeing myself weekly since 2015. He works on a farm for about 2 to 4 hours a day, and his boss has methamphetamine use disorder. So every day he goes to work, he sees a meth pipe, but he feels as if, you know, he can handle that because he just loves working with the cattle and the cows and fence and all those kind of things. He has overdosed purposefully 3 times in his life. In the spring of this year, he had an inadvertent overdose on methadone. He really regretted the use. He required an ER visit, but he has not used methamphetamine in 2 years. Which when he gets on methamphetamine, he becomes very dysfunctional. and almost psychotic. And I think with his last use 2 years ago, it scared him so much because it took him so long. I bet it almost took him at least 6 months to a year before he felt like his mind was back to where it was before. He is taking kratom. He takes either 0 capsules or maybe up to 4 capsules a day, which he feels just kind of helps him. He does continue to drink alcohol, and that seems to kind of be his big issue right now. And I think for him, with all of his polysubstance use, he never thought alcohol was an issue until he quit methamphetamine, he quit opioids, he quit smoking cigarettes. And so it's kind of like that last thing that he's fallen back on. He's also pretty stubborn. He doesn't like to participate in local AA or NA because he feels like sometimes when he goes to NAAA, he did try an intensive outpatient program, but he gets hung up on the all or nothing thinking, and he really seems to do well with harm reduction approach. But it seems like when anybody tries to start really pushing him on things, he pulls out. And so that's kind of where we are right now. I think with him, harm reduction has been the best for him. He is contributing, he is working, but he's still a work in progress and still trying to make good choices. And so I didn't know if anybody else had any thoughts. He's read a book. We've been working on like a Dharma kind of book, and that seems to be helping him a little bit more because his parents were very religious and very strict when he was growing up. So sometimes too with AA, he's not fond of that, just with all the religious connotations and beliefs that they use in that. So I didn't know if anybody else had any things that ideas or things that have worked for some of their patients or thoughts.
I was wondering if anybody had experience with some of the online smart recovery or some of the online kind of other approaches, or Gayle, if you felt like that was something that was possible for your patient.
He has got online. He did look at smart recovery, but I think because it was virtual, it was hard for him to engage and stay focused. And so that kind of wasn't successful either. Over the past year, one thing that I really have been trying to encourage is that he repairs some of the relationships with his children. Pretty much his kids and stepkids, he had introduced them to drugs and they struggle now. He has a grandchild with neonatal abstinence syndrome. And he started to repair those relationships. And it seems if we can either have something for him to look forward to, like maybe going to a concert or maybe going on a visit to go see one of his kids, that really seems to help. Just to kind of keep him engaged a little bit, because if he really starts to isolate, that's when all that negative thinking and thoughts really start to impact him. And then he starts looking for other avenues to get out of his head, so to speak.
Gayle, can I ask you a question? Because you
Sure.
said something super interesting. And when you just said that he gets into thinking about abstinence and focusing on pure abstinence rather than harm reduction. And that's such an interesting point. And I feel like I've seen so many times that it's the patient who stigmatizes themselves the hardest.
Yeah.
And that can become such a barrier to improvement, right? I've seen where people have done very well with kind of long-term abstinence, and then they had a single relapse a few weeks ago, and they're still just banging themselves over the head with that. And it feels like our job in that situation is to work hard for perspective. I think that's what you were saying. Am I getting that right?
Yeah.
Because it seems like such an important point, especially, you know, in terms of preventing the next relapse or delaying it, if you will.
And I mean, and I'm just tickled that despite wherever he's at over the last 8 years that I've seen him every week, he shows up. And even when he was on methamphetamine, he was showing up, and he was disassociating and he was hallucinating, but he still came to his appointments, and he really wants to do better. And so, I mean, that harm reduction, is it perfect? No, but at least he's able to repair relationships and work and just kind of be happier with himself.
What could be more important though than he shows up, right?
Right.
In your treatment, under your care, you're continually reducing harm. I think that is like a fantastically important point. So that's really cool to hear you say that.
And I mean, and I think that was really hard for me to come around to too, because, you know, back, 10 years ago, if people were misusing your opioids or you have that contract, you fire them. We live an hour and a half away from any metropolitan area. And if someone doesn't take advantage of treatment, the people here will never get treatment. And so, and pretty much everywhere in Nebraska is rural for the most part. And so, I mean, that's kind of what triggered me to start treating opioid addiction and opioid use disorder, just because no one had anywhere to go. So.
Super cool.
It is.
Hey, we had a good question in the chat. I can read it quick here. From Heather. She says, I hear many clinicians and prescribers that they do not complete the appointment assessment when someone arrives to the clinic intoxicated because they don't believe the informed consent is possible in that state. What do you recommend with that?
I know that sometimes when I have patients show up for their appointment, they're in withdrawal and they are miserable. And so we just kind of go over, hey, let's get a plan. Let's get you on Suboxone. Let's follow up in a week and we can go over the full assessment. And that is something that was hard for me at first too, because I felt in my mind, I needed to have all this documentation. I needed to show that there was opioid use disorder. I wanted to be sure my documentation matched what I was treating. And I've kind of let some of that go a little bit because over time, it just seems like too, the more you talk, the more information, the more you learn about them. And that was hard. That's been hard. So that's the way I go about it.
I think it's part of that low barrier care, because if you maybe they'll never come in not intoxicated, and then what do you do? And so I agree with Gayle, and we go ahead and proceed, and for us too, for me anyway, it was hard to kind of let go of having that full assessment before starting kind of medicines. But I think it was actually Dr. Janet that really sort of, talks about this in a really good way about, just get them started. And because without that, they will never our patients will never like get well because the withdrawal is horrible. It's true suffering, and if we don't offer some solutions to that, those folks will never kind of find their way through it. So, I don't know, Janet, do you want to talk about that a little bit?
Yeah, and I see a question in the chat that we can address as well. Yeah, in my opinion, once you do it a few times, you stop being scared of it. And you really have to meet patients where they are and understand that if you can get off on the right foot, which means compassionate care, you listen to them, you figure out the issues, you express your desire to work with them to help them, they'll be back and you will develop a full relationship where you end up knowing everything about them and you can flesh out your assessment going forward. There is a question in the chat about starting buprenorphine in the emergency room. And I think that is very important. That is a first point of entry into the healthcare system for some of these patients, and a frequent point of interaction with healthcare. And it came to pass in North Platte that as our emergency room doctors knew that I did this, they would call me and we'd get them started. I'm hoping that now that the waiver thing is a thing of the past, that we can actually get some people starting it and passing the patient off to a provider in their community, because that is such an important entry point for people. And a lot of these patients are repeated, go to the emergency room a lot for many reasons. So if you can communicate with your ER, I think that's great. Go ahead, John.
We do have plans, and we talked about our next echo series. We have plans to make an entire echo regarding that very subject. And in the interval, especially if you have, upcoming questions, one of the things that all of us on the echo team, are available, we can discuss that offline because it's a bit longer conversation probably than we have left in this. But if you want to reach out, we can discuss it in the interval, but we're planning an echo specifically for that, because the data shows, I think Gayle and Ken said earlier, data shows if you see somebody in the ED and they're in need of services, if you get them started at the visit, you have a much higher rate of conversion to long-term care, and that's obviously important. So we're going to bring that forward.
The only way it works, though, is if you have folks in the community willing to see them like the next day or the day after, and that's really the important part of it, is establishing with folks in the community. And again, one of those places I think where APPs are a gigantic part of that solution.
Well, we're at the end of our hour here, it looks like. I put in a link to the evaluation survey for today to get your CME certificate. I'll also be shooting out an email before noon today, later this morning. If there's nothing else, thanks everyone for joining us today.
Thanks very much. Great job,
Thanks,
Gayle.
Ken.
Thank you, Ken.
Great job.